Okay, so I will start right now. Like the title says, it's an introduction to ICD Flexfit. This is a lens designed by CAT Group. So we will start right now. My name is Ricardo Duarte, sorry. I'm the lead consultant for Spectrum International. And I'm here to help you with any order that you may have later on. So let's talk a little bit about the ICD Flexfit. So the ICD Flexfit is designed for, so sorry for this mishap, for any eye shape. The construction of the lens makes it possible to clear or bold the cornea regardless of the condition, from a normal eye shape to ocular surface diseases, through corneal thinning disorders, transplants, and post-refractive surgery patients. ICD Flexfit simply needs to create enough bold to clear over the eye surface regardless of its irregularity. So as you can see here, I mean, this is a PMD. We have an oblate cornea here. So whatever the condition that you may present or your patient may present, you can use ICD Flexfit and it will cover all of these types of shapes of corneas. So sorry about this. Let me just skip. So as we know, what we try to do with the scleral lens is bolt over cornea, peripheral cornea, limbus, and just to create enough clearance between those, the sensitive tissue, that is the cornea. So we need to emphasize on having enough bolt to ensure that we do not touch or bear on the corneal or limbal surface. And this is very important just to avoid any type of issues later on with the lens touching the cornea, right? So ICD Flexfit has two standard diameters that can accommodate small and large fissures, small and large corneas, low and high sag eyes, and fitting inside or outside pingueculas. So we have the 14.8 and the 16.3. And actually, you will see later on, this is how the fitting set is built. So two standard diameters in the fitting set that you have for your patients. So, but how do we choose the correct diameter? I mean, there's a rule, and as you can see here, the rule is basically just some people say 3.5 and some say 3.5 or 4.5. And that's kind of the way that you choose a diameter. But I mean, you have to take into account whatever your patient is presenting to you. I mean, if you have like a keratoglobus or a very, very, very steep keratoconus, you wouldn't go with a lower diameter, right? Just thinking, let's say you have an 11.5, because you can have an 11.5 HPAD and have this very steep keratoconus, and adding a 3.5 may not do the trick for you. So you need to go maybe larger. I mean, you are very tied up with the fitting set just having a 16.3, but you know for sure that you may need to increase that diameter. And that's where what we can do with the ICD Flexfit. So as this slide says, the 16.3 is less sensitive to visible iris diameter considerations. I mean, I usually tend to go based as well on the profile of that cornea. I like to look at the patient's eye and just have the patients turn sideways and just take a look at that cornea and just really assess how much larger I need to go, because that will give me a proper weight distribution later on, just having a larger diameter, right? So as I was saying, you can just go smaller to a 14.5 with a 14.8, or larger up to 15.5. That's the modifications that you can do, and you can do that modifications 0.1 steps, right? So for the 16.3, you can go down to a 15.5 and pick it up to a 17 millimeter lens. So remember, if you have eye surface disease, you may want to cover as much as possible as well. So that's why it's so important to have all those questions answered, and just to know your patient really well, just to see what you need to pick up, and just to really get the best diameter for that patient. So, but you have the ability to change from the fitting set, from the 16.3, and that's how far you can go and how low you can go. So one other thing is that the 16.3 comes with toricity on the posterior surface of the lens. And that is because as close as you are to the limbus, the more regular the scleral shape is, right? The more even the height of the sclera is. But if you go outside the limbus, and if you go far and farther away from the limbus, then you may need more toricity. Studies from Pacific University made by basically the designers of this lens, Randy Kojima and Patrick Caroline, studied that going farther from the limbus, you have to have approximately 150 microns of toricity. And basically they did some studies, and 78% of the population that they studied was well fit with 150 microns of toricity. So that's what is built in the 16.3. I used to, well, actually not me, but a while ago, this was in the GSLS convention in Las Vegas, where all the top-notch contact lens fitters go. They were saying like, oh, so you see, the having toricity fitted on every patient is not necessary. Nowadays they have like made some more studies, and that is why, as you may see now, every fitting set has toricity, just because the studies really display that going farther from the limbus, I mean, your sclera is more toric. We all know that the horizontal meridian is the more high meridian, the more flat meridian, and just knowing that the vertical meridian is the more steep or the more closed meridian, right? So that is why we need the toricity for the majority of the patient, because we now prefer to go larger in diameter because it gives them more comfort when fitted right. So I want to remark here that the hash marks that you see here, this one and this one, are put in the flat meridian. The toricity is put in the steep meridian. These hash marks don't always tend to go like 3 and 9. They could go wherever they may settle, and actually that is okay with it because they will try to find the flat axis or the flat meridian of that sclera. So that is something to take into account. Just knowing that these hash marks that you see here are put in searching for that flat meridian of the sclera. Just remember that having let's say corneal cylinder and the sclera toricity is very independent, one from another, sorry, and they are very different axes. And just having, like, let's say with the rule corneal seal, that doesn't mean that the lens will settle at 3 and 9, because the sclera toricity is different and it may settle different from where you're seeing the corneal seal. So whenever you are seeing a topography with the rule or against the rule, don't expect that to be the lens settling in that flat axis. So just be aware of where those hash marks settles, because that's gonna be very useful whenever you're doing like a bitoric lens, because that's gonna mark where the lens is stable. So you have to be very careful. And as I always say to every practitioner whenever I'm giving a lecture, is just really notate, just take notes where the lens is settling, and just have it in case you need it. So you can always do and perform a rotational test. Just switch the lens 90 degrees and just tell the patients to blink and just see if the lens really returns to that position that you notated at first. If it does, then you have a very stable lens and you wouldn't have any issues. But if it doesn't, then you may need to address the landing zone, and you may need to change even toricity. You may request more toricity, less toricity. It will depend on what you're finding. So so the ICD Flexfit 14.8, that comes as a symmetric, like it says there, due to the symmetric nature of the sclera where it lands. So because, like I was telling you before, the lens is resting more near the limbus, and that's a more even shape of the sclera. So you can always ask for the 14.8 to have toricity, and it comes symmetric, but you can ask for toricity if you need it. I mean, let's think that like you are seeing edge lift and you are getting dye ingress on opposing quadrants, then you may request to have toricity. It's not uncommon. It's less common for sure, but it's not uncommon to ask for it. And as well, you can ask 16.3 just to be a symmetric lens without toricity. That's again, it doesn't happen that much, but it can happen. So just be aware that you can order whatever you need with those lenses. Okay. So one of the things that ICD has is that it has multifocal lenses, designs, sorry, and you can ask for distance center or near center. As you can see here, this is the distance center, and here in the outer part is the near vision. Here, the near zone is at the center and the distance is far away. This is You can ask for the distance zones to be custom made, varied zones, like you can ask for a smaller zone, a medium zone, or a larger zone. As well, with the near zone, you can ask as for different types of diameter of the near zone. So that's available to you. Just remember that when you are fitting a multifocal, you need to have three basic things: a good centration, good disponibility, the patient to be very flexible about using multifocals, just because the the curve, the learning curve, sorry, is could be very steep, and they could feel eventually less motivated just to try it, because they can be very susceptible to the changes in vision. And minimum, and this is something said by Dr. Greg Denayer from the United States. And what he says is just having a good distance BA, like 2025, that will do most of the times a good fit for multifocal. And just having those three things will help. So yeah, doing multifocals is very useful when you have all those strings together. It could work very easily for you and your patients, because if it doesn't, sometimes you can have your patients just asking why they are not seeing the way they are supposed to. So again, with the ICD Flexfit, like I was telling you before, you can do anublate lenses, and you can do as well a prolate lenses. And this can be done with some modifications that you will do on each zone of the lens. The lens has four, let's see, four zones, sorry. I was just trying to remember. So we will talk a little bit about those zones later on. So this is the diagnostic set. As you can see here, you have a good display, and actually this is a very useful table where to start, with what type of condition, with which SAG. Just remember that you have to do SAG when you order. You need to explain which SAG you tried on. Like, let's say you are ordering a 4,000 microns of SAG, 16.3, with this is the actual power of the lens, and you can just add the final power, or you can just send the over refraction. I don't know about you, but we usually do just the final power, right? It's less confusing for the lab, just having the final power. And I know Ilker has sent final powers, so that's very useful. So like I was telling you, this is a little table which explains where to start. I mean, this is for a normal eye shape. This is a keratoconus. This is a transplant, and it's suggested to start. And you can see it in bold writing, like to start with the 4,000, with the keratoconus, to start with the 4,400, and with the transplant, just go with the 4,800. So you have a way to choose which lens to start, as well with the 14.8. Basically, there's just one for the normal eye shape. Keratoconus, you have three lenses, but it says it's suggested to start with the 3,800, and for the transplant, you have one with the 42. I mean, I'm not sure, but I have seen very few orders with a lower diameter nowadays. I mean, it's very useful to have it. And I will say, it's better to have it and not to use it than need it and not having it. So let's say a small kid with an irregular cornea, you can fit the 14.8 just as it could be like a soft contact lens. So yeah, it's a good thing to have the 14.8 as well, and it's already built in the diagnostic set. So yeah. So this is again the diagnostic selection of the lens. Um, just to go what comes in the diagnostic fitting set. Um, the scleral lens application, I mean, we already know. The most common is just to have the plunger and just fill it with saline solution. There's another way to apply the lens just with the tripod method or two fingers. This is the more unstable way to put the lens in, but I mean, we can always show them. I mean, I would do this with a 14.8, not with a 16.3. But just having the plunger is most of the time the solving solution for inserting the scleral lens, right? So like I was telling you, just having the preservative-free saline solution and fluorescein and just do the assessment, right? If you ever presents bubble after inserting the lens, just remove it and reapply. I mean, that's that all we know that just having this type of bubbles. What I usually like to do is when I see this and when I fit the patient and just have the patients feel the bubbles, because the bubbles will lower his visual acuity, and it could create sensitive like it could the patient could feel just having that bubble and it could bother him. And I usually like to have this at first just because I'm trying to make them aware. If they ever feel that, just remove the lens and fill it up again and just insert the lens again. That's a good way to make them feel this uncomfortable and just knowing what to expect. So, but if you have a touch or a near touch is present, like in this case, this is not a bubble, as you may see, then we want to go and make some changes in the parameters, right? So like I was telling you, ICD Flex has a central zone, a peripheral zone, a limbal zone, and a scleral landing zone. So this is managed by the base curve. These are managed by steps that we will see later on, as well as the limbus and as well as the scleral landing zone, right? So again, here's just in a different position. And as you can see here, you can see, and they are just representing how the changes in parameters look like. I mean, it looks a little bit smaller. I will make it larger in a few slides, so bear with me. So just to know that ICD Flexfit adjustments will alter sag from different areas, right? So let's say you are changing the base curve. Obviously, the only section that you will be altering the sag is the central zone, right? So you can go up or you can go down, and none other of the other zones will be affected by those changes. But if you change the peripheral corneal zone, then this will affect the central zone, but this won't affect the limbal zone, neither the scleral landing zone. If you change the limbal zone, it will change the peripheral, and as well, it will change the central. But this won't change the scleral. If you change the scleral landing zone, this will affect limbal, peripheral, and central. just to maintain a good relationship between those changes, right? So as you can see, you can go up or down, up or down, up or down. Okay. So the central clearance zone, like I was telling you, is managed by base curves, and 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 one diopter change in base curve would affect 50 microns. That's the change that you are making, changing one diopter. Just remember, if you steepen, then you're steepening one diopter. That diopter that you are steepening, you have to add it to the power just to maintain the lacrimal between the lens and the cornea, right? So let's say you have a -1 and you decided that you needed 50 microns and you are doing it on the base curve. That diopter will change the power to a -2, right? Just the good old SAMFAB rule, wherever you steep at minus, flat at plus, right? So just be aware of that. Basically, what is suggested is changing the base curve will be greater or well done when you are seeking to change over 200 microns. Less than that, you can do it with the peripheral curve. That will be the go-to modification that you need to do in order to change the central side. And that wouldn't affect the power of the lens, sorry. So like I was telling you, the peripheral curve is in this area here. And this, like I was telling you, will affect the central side. So changing this, you will change this in 25 micron steps. What is suggested is just not going over 200 microns. I mean, if you go over 200 microns, you might as well just change the lens and go to a different sag. Because if we go back to the fitting set, like back here, I mean, if we are doing a 4200 and you are needing to change the peripheral curve, the peripheral zone curve by 200 microns, you might as well go to the 4400 because you're already gaining those 200 microns at central clearance, and it will maintain the relationship between all the zones, right? So as well, if you need to decrease more than 200, just go back to the 4000 microns lens. You don't need to, I mean, what's the most time that you will take just by changing the lens? Maybe a minute. I mean, that's even if you go slow, you can do it in less than a minute. So I would strongly suggest just to change the lens and just see it with your own eyes. Whenever you are more experienced and the learning curve is past, you can just make the modification as you go. But if you're starting with the ICD Flex, I will suggest to change the lens, drop it down, or go up and see what it looks like, right? So central clearance zone, so peripheral. So these are the changes, like I was telling you, up or down, 25 micron steps. What is suggested by Randy and by Patrick Caroline is just going +6 up to +7, as you can go higher up to +7, just changing 175 microns if you see this is what you need, but not going over the 200 like I was telling you. The limbal clearance, here it is positioned here as well, changing the limbal clearance, and this graph just shows you which zones are altering as you go. So as you can see here, changing this one maintains the relationship all the way. So with limbal clearance, whenever you're seeing touch or bearing or heavy bearing, an appropriate change may be a +5, just taking into account that that is 125 microns that you're changing, and just remembering that the lens will drop down and you may want to go a little bit higher, just because the lens during the day will drop and that area will drop as well. So whenever you're seeing like heavy bearing of the lens and the limbal area, you may want to go a +5 and just taking into account that the lens will drop eventually. But here's the tricky part. Let's say you make a +5, but you already have here like a good 300 microns. I usually prefer to go with whenever I'm just putting the lens on, just having 400 microns, I just feel comfortable with that. I don't know about you, but I do feel comfortable just having 400 microns, just because, like I was telling you, the lens will settle eventually. And when the lens settle, it will drop down around 100 to 150 microns during the day. So just thinking, having 400 microns and dropping 150, and we'll have 250 microns of central clearance, that's perfectly fine for me. Langis Michaud did this study that a good fit was between 200 and 400 post settling. So I feel comfortable with that. I know Maria Walker, an ex-president of the SLS, the Scleral Lens Society, she feels comfortable with 150 microns. I mean, after settling, so that's okay with her. But I just feel comfortable having that cushion, because that will give me eventually during the years, if the lens start to flex, the material starts to flex, and if it drops a little bit more, I still have a good clearance for my patient, and the lens will maintain. So going back, let's say you did +5 and you had 300 microns here and you are okay with that. If you do a +5, these 300 microns will go up 125 microns, right? So then you will have 425 microns. So what you can do here is just neutralize this change in limbo with the peripheral. So you can just go, sorry, +5 here and drop down -5 here. And that will maintain the relationship, and that will maintain the 300 microns that you have here. So you can either play with the zones and just go up or down to maintain the central clearance if you are okay with that. I mean, but let's say you have 200 microns here and you want to leave 300 microns, just going 125 microns here, that will raise up here to 325. And I mean, 25 microns is very uncommon for the eye to see. So 25 microns wouldn't do that much of a difference. So I would just leave it as it is. I wouldn't even compensate with the peripheral zone and change those 25 microns that I'm gaining extra. That's okay with me. I mean, but what it's okay with me, it could be not okay with you. So do as you feel, but you just know that you have the ability to change as much as you like. And the scleral landing zone, of course, is where the weight of the lens rests. And just know, and that's something extra for the central clearance, just having too much central clearance will decenter the lens and will create more pressure on the scleral landing zone, right? So that is why you have to maintain as well a good relationship over that of the central clearance. So as well, here you have the scleral landing zone, and you can go down, which going down here is just getting more near the sclera, and going up, that will flatten the scleral landing zone. So that's something to take into account. So when and why to do those types of adjustments? So just give me a second here. Sorry. So the ICD Flexfit was designed for the median scleral angle or middle of the bell curve in the patient population. If you place an ICD Flexfit on a patient with a flat scleral shape angle, the edge may fit tighter on the sclera, like you're seeing here. Like if the angle of the sclera is flat, and it could just go down, and then you will need to go up with flattening that scleral. So increasing the edge lift is necessary in this type of cases. So you may need to order a scleral landing zone whenever you're having a mild vessel restriction, whenever you're seeing opposing quadrants with blanching, then you may want to go to a -2. And if you are seeing more than 180 of vessel restriction, then you may want to go with -3. Just take into account that doing this -1, this -2, or this -3, let's say this is 25 microns, 50 microns, and 75 microns. This will lower the way the lens, the central clearance, right? Because you're opening that sclera. So the scleral landing, so sorry. So let's go back. So as you see here, whenever you are opening here, the lens will settle a little bit more, and that is why you are dropping down. That is why you are doing a negative change whenever you are flattening. Whenever you are steepening, you are doing a plus sign. So let's say you have edge lift and you want to close that lens, you are doing a plus sign. And you are doing that because you are lowering here and you're raising the lens in the central area. So that is just for you to know that whenever you're doing a flattening of the scleral landing zone, you are doing with a negative sign. And whenever you are doing the deepening of the scleral landing zone or closing the scleral landing zone, you're doing with a plus sign, okay? So what are the advantages of having the ICD Flexfit? No changes in nomenclature, central clearance zones, peripheral corneal clearance zones, limbo clearance zones, scleral landing zones. Like another benefit is just having one set for any type of eye, like I was telling you before. Those that you see here in gray, you can ask for them to have it and extend the fitting set. So you can ask for more lenses for your trial set. Like I was telling you, just having those lenses for any type of eye, that will be that is awesome to have. Nowadays we are more invested on scleral lenses just because of the how comfortable they are for the patients, but as well we know the prices are very steep for some patients, and so that's something that we have to manage. So somebody asked me a while ago, like, so what do you do? How do you make the sale for a scleral lens? And actually it's not the sale for the scleral lens as well as it is like I'm providing something for that patient that he needs in order to see well and just feel fine. Most of the patients that goes for a scleral lens fit is are patients, sorry, that has any type of these conditions that you're seeing here. And whenever you can make them feel, what I always tell them is just having three things together: comfortability, good vision, more vision, visual acuity, sorry, and quality of the visual acuity. And if we gain those three things, then we are on the right track to have a better life. And whenever I do that, whenever they try the lens on, they just feel so fine with that. And I mean, they just purchase the lens because they see the benefits of it. So it's not that we are trying to make everyone just go to a scleral lens. It's just with the needs of the patient, make them go to the scleral lens most of the times. So like we were saying, two different approaches, two diameters, one approach, sorry, 14.8 and a 16.3. And I'm just I do apologize because I do want to correct myself. The 16.3 has 125 microns of toricity. So it's not 150, it's 125. So again, the lens is built for an oblate cornea or a prolate cornea as well. You can make it more prolate or more oblate based on the needs, and you can modify that through all the zones that you see. I mean, if you want to go to an oblate descent, what you may need to do is just raise a little bit the peripheral zone and just drop down the base curve. You can do that, or you can just lower the peripheral curve, and that will drop down the center zone. So you can do an oblate design just like that. So like I was telling you, ocular surface disease may not want to go with a 14.8. I just may want to go with a larger diameter just to have the lids go over and not touch any sensitive cornea. So yeah, I will prefer just to go larger in diameter for ocular surface disease. Again, selecting the diameter, there's just like the standard rule, but if you can go and just go deep into selecting the proper diameter, that would be awesome. Sorry. Again, a small or large fissures may require a small diameter or a large diameter. And as well, one set for symmetric and asymmetric sclerals. So yeah, this is ICD Flexfit, multiple diameters, symmetric and dual depth or toric lenses. Asymmetric, you can just order with the 16.3 to have quadrant specific as well. Multifocal and displaced optics. These displaced optics are for the multifocal, right? And so that's about it. I don't know if you have any questions that I may answer.
Ricardo?
Yeah.
Thank you very much.
Yeah, of course.
Okay, thank you.
If you have questions, you can either send it on email or you can ask me right away. I'm here for you.
Okay. Thank you very much for the presentation, Ricardo.
Oh, okay, yeah.
Finish.
Yeah. So do you have any questions for me, or are we okay? Was I good and clear, or do I need to assess anything? Let me know. I will gladly do it.
Okay, Ricardo. Thank you very much, presentation. Good night.
Okay, Ilkar, good night. Gladly
Thank you
to be
very much.
here.
Thank you very much.
If you have any question, please write it down and I will gladly answer for you. Okay?
Okay, okay.
Okay, thank you.
Thank you. Thank you.
Have a good night. See you Thursday. Bye-bye.
Night you. Bye bye.